My name is Michael Matthew, and this is Pathways number 4. Case number 1 states a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. Which diagnostic would be best to distinguish between a urea cycle disorder or a disorder in beta oxidation? Plasma glutamine will most likely be the best diagnostic to use in this case. Because of the role that plasma glutamine plays in the urea cycle, by measuring plasma glutamine levels, it should be clear where the issue lies with this patient. Ammonia is a product that is continually made in the body. Ammonia crosses the blood-brain barrier, and too much of it can have toxic effects on the brain. However, ammonia that is produced during metabolism is detoxified for a while by being incorporated into the amino acid glutamine, which is not toxic. This can then be transported safely into circulation to be released, and then removed as urine. This serves to keep ammonia plasma levels low. Hyperammonemia occurs when the urea cycle does not function properly. The load may be too great, or transport may bypass the liver. Under these conditions, it can be expected that plasma glutamine levels will be lower than normal. In urea cycle, disorders can also occur due to deficiencies with argininosuccinate synthetase and lyase. Urea cycle defects tend to be the result of deficiencies in enzymes involved in the degradation of proteins. When this occurs, nitrogen accumulates to form ammonia. Ammonia can increase more rapidly in the plasma in patients with liver or metabolic problems. This is especially true of issues with increased deamination of amino acids by deaminases. In this case, blood glucose would not be the most effective diagnostic because it is not significantly more or less influential to the urea cycle or beta oxidation. While a rise or a decline in blood glucose may play a role in both of these processes, it would not allow you to determine whether one or the other has a defect. Urinary acids would also not be the best diagnostic because urinary acids would be involved heavily with both urea cycle and beta oxidation. Beta oxidation is oxidation of fatty acids, but fatty acid metabolism also plays a role with the liver. By just looking at the urinary acids, it would be hard to tell whether the actual issue has to do with fatty acid processing in the urea cycle versus beta oxidation. I think that for a similar reason, serum fatty acids would not be the best diagnostic. Fatty acid levels are heavily connected to the urea cycle and beta oxidation of fatty acids. Therefore, I do not believe you would be able to use serum fatty acid to definitively determine the issue. In the second part of the question, the patient's blood ammonia level is elevated, which is expected with a urea cycle and plasma glutamine defect. In cases of urea cycle defect, ornithine transcarbamylase is often deficient. This is often associated with hyperammonemia. Phosphate-activated glutaminase may also be overly active in this patient, as this enzyme is responsible for increasing ammonia levels. Citrulline is a non-essential amino acid that is synthesized during the urea cycle through addition of carbon dioxide and ammonia to ornithine. The plasma citrulline level was normal, so it is likely that there is no deficiency regarding citrulline. It can also be produced from arginine. Citrulline residues can be generated by peptidyl arginine deaminase enzymes, which convert arginine into citrulline by citrullination. A defect with peptidyl arginine deaminase could be connected to the urea cycle issues. Regarding the high orotic acid level, the enzyme dihydroorotate dehydrogenase may be overproductive. This enzyme converts dihydroorotate to orotate in the de novo synthesis of pyrimidines, so it could be responsible or high levels of orotic acid. As such, one enzyme that may be defective is uridine monophosphate synthetase, or UMPS. This enzyme is responsible for regulating orotic acid levels, so those with the defect in this item may also experience urea cycle defects. Patients with low levels of this enzyme are not able to break down orotic acid efficiently, so it builds up. Case number 3 states, a 47-year-old man presents with severe pain on his right great toe. He is unable to bear weight on his right foot and there is no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. The results from this individual are listed below. In this patient's case, their plasma uric levels are slightly above normal at 10.5 milligrams per 100 milliliters. This is versus the standard 7.0. The urinary acid is low at 215 milligrams per 24 hours versus the standard 413. Uric acid excretion is important because it is involved in calcium and uric acid stone formation. This indicates that there is most likely more of an issue with excreting uric acid than overproducing it. The patient is most likely to not have any issues with producing uric acid, but having problems removing it from their system. Uric crystals form when there are high levels of uric acid in the blood. Gout occurs when there is a buildup of uric crystals in the joints. This can lead to inflammation and intense pain. The gout is a result of uric acid not being properly deposited through the urine, most likely in this case. The kidneys eliminate about 2/3 of uric acid, and the gastrointestinal tract eliminates about the other 1/3. Most uric acid is filtered through glomeruli, and the post-glomerulus reabsorption and secretion control the amount of uric acid excretion. This process is most likely not properly functioning, resulting in a higher plasma urate concentration and a lower urinary uric acid concentration in this patient. I do not think that the overproduction of purines is the most likely root cause. An overproduction of purines will cause an increase in uric acid because purines are broken down into uric acid, and there's already a lot of urate in this patient's plasma. For a similar reason, decreased salvage of purines is probably not the most likely root issue. Urate is already abundant in the plasma, and scavenging purines would only produce more uric acid. Uric acid is reduced when purines are broken down. Purines are also found in some foods, like certain meats such as turkey and seafood. Uric acid levels are also driven by alcoholic and sweetened drinks. Most of the sweetened drinks that increase uric acid levels are rich in the sugar fructose. Plasma uric acid levels increase with increase in purine levels, which directly leads to gout. By incorporating 4 to 5 liters of soda into the diet, this patient has greatly increased his susceptibility to gout. As he consumes fructose syrup through his sodas, that fructose is converted to purines, which are further converted to uric acid. Uric acid is the end product of purine metabolism, and dietary restrictions of purines can help decrease its urinary secretion. It would definitely be recommended that he cuts down on the sugar in his diet.